We'll get started in about 1 minute.
Okay.
Okay, Daljeet, we'll get started now. Hello, everyone.
Okay.
Welcome to this month's What's New in Addiction Medicine, the first session of the new academic year. I'd like to welcome all of our incoming fellows, and I'm very excited for today's talk from Dr. Daljeet Mahal to kick off the series. My name is Paxton Bach. I'm the Program Director for the Addiction Medicine Fellowship. And for those of you who are new to this series, this is our monthly rounds where our Addiction Medicine Fellows will present on a topic, either a new topic or updates on a topic in clinical addiction medicine. Today we have Dr. Daljeet Mahal with us, who's going to present on emerging buprenorphine-based treatments for opioid use disorder. So Dr. Mahal is a fourth-year psychiatry resident whose training has been focused at the Fraser Health sites in the Lower Mainland. Prior to completing medical school at the University of British Columbia, he completed a graduate degree exploring human microbiome research and also spent time working at the BC CDC coordinating research projects involving mobile health. His interest in the field of addiction medicine first started while volunteering on the Urban Health Unit at St. Paul's, and it's grown from there. He hopes to apply the skills gained from this fellowship program to expand access and availability to addiction and mental health services in the Fraser Health region, with a specific interest in developing resources for the Punjabi-speaking community. So his talk today, as I mentioned, is entitled Emerging Buprenorphine-Based Treatments for Opioid Use Disorder. I think this is a really fantastic subject and something of great interest to us these days, as we are starting to see more and more formulations and approaches coming out. So with that, I will turn it over to Dr. Mahal. He'll give his presentation. You can feel free to type questions into the text box, and we will do a 10-minute Q&A at the end of this presentation. So take it away, Daljeet.
All right. Thanks so much, Dr. Bach, for that introduction. And thanks to everyone who has joined in for the talk today. Before I begin, I would like to respectfully acknowledge that I am a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I have no conflicts of interest to declare. So the focus of these talks, as Dr. Bach had mentioned, is really to speak about what's new and emerging in addiction medicine. In full disclosure, I'm just in my first addiction medicine fellowship, so a lot of what I'm seeing and learning is new to me. But with that said, what I want to accomplish with today's talk is really an overview of local BC public health demographics in relation to opioid use disorder, do a review of the buprenorphine pharmacology and what the traditional guideline-based induction technique is to get people started on to buprenorphine, and then really get into the focus of the talk, which is to really review what the evidence is for some newer ways of getting people started on buprenorphine using microdosing techniques. And then I want to actually get into shifting from speaking about starting people onto buprenorphine to keeping people on treatment with the goal to prevent relapse, and speak about two of the emerging methods around that, including a subcutaneous implant as well as a monthly depot injection. So to start with, what I think is really essential and important is to highlight the context of where things are at with opioid use disorder here locally. in BC. And this is data from the BC Coroner Service. Along the x-axis, it's the years from 1995 coming all the way up to this year, 2021, and the data is up to May of this year. And along the y-axis here is the number of deaths from drug overdose that have occurred per year. And what I wanted to highlight in this slide was where we see an increase in really the number of deaths occurring, and where there's a visible peak here starting in the 2015-2016 year and continuing to go up. And in 2016, that was the time the opioid overdose crisis was declared a public health emergency in BC. And the other thing to highlight in correlation with this is when looking at the specific types of drug content found in relation to overdose deaths that have taken place over the last 8 years, that 2016 year also coincides with a peak in there being a higher level of fentanyl detected in the illicit drug supply. And that's what's highlighted here in black is the presence of fentanyl being more strongly correlated with drug overdose deaths. And then to further emphasize the impact and the ongoing crisis with opioid overdose, this is a graphic here along the x-axis here is going from January 2020 to May of 2021, covering the months over the pandemic. And what's highlighted here in the purple bars are the number of overdose deaths that have taken place per month, and that contrasted with the deaths that have taken place due to COVID during the pandemic. And this slide is really to highlight the increase, the higher overall number of deaths due to drug overdose, even during the pandemic. So shifting more towards the focus of today's talk is really to talk about treatment strategies for opioid use disorder. This slide here is really representing the spectrum of treatment for opioid use disorder. And what I'll be focusing on is what's highlighted here in the middle box, the peach colored box, and specifically speaking about buprenorphine, which is considered the first line treatment for opioid use disorder. So buprenorphine, it's a synthetic partial mu opioid agonist, and it's also a kappa receptor antagonist. And what is pictured here on this slide is the most commonly used and available form of buprenorphine, which is in the sublingual tablet form. So some of the properties that are important to note about buprenorphine is that it does have a rapid onset of action where the effect can be felt usually by about 1 hour, and it does have a long duration of action as well. And that duration of action increases with increasing dose of buprenorphine. And then what's highlighted there at the bottom of the slide is if someone is onto a dosing of 8 milligrams or higher, you're covering over 24 hours in terms of the duration of action. Now, some of the unique properties of buprenorphine which lend to it being a first-line treatment, one is that it does have a very high affinity for the mu opioid receptor. And that's what's being shown in this graphic on this slide is basically the binding affinity is along the x-axis with a smaller number being correlated with a stronger binding affinity. And the red arrow is pointing to buprenorphine, which is being ranked high amongst other opioid agonists as having a very high binding affinity. And the reason this is important is because if a person does have other opioids in the system, buprenorphine, because of its, despite it being a partial agonist, because of its high binding affinity, it will tend to knock off or displace other full opioid agonists. The other specific unique property to highlight about buprenorphine is because it is a partial agonist, it does have a lower intrinsic activity than full mu opioid agonists. And what's being represented here in the graph on the side is when you look at methadone, which is in red, you can see that there's a dose-dependent effect where with an increasing dose of methadone, there is more of an opioid effect. And with that comes some of the concerning effects from opioids, such as sedation as well as respiratory depression. This unique activity of lower intrinsic activity with buprenorphine, what is very protective about it is with the increasing dose of buprenorphine, what we find is there's actually what's called a ceiling effect, where at higher doses, there isn't further exacerbation towards sedation or respiratory depression. And in that way, this is it's a very protective factor about buprenorphine. Now, in terms of some of the challenges with buprenorphine, those two same unique properties that I highlighted, having the high affinity and then the lower internal activation, the difficulty with that is when someone does have other opioids in the system, such as heroin or methadone, if buprenorphine is introduced, it will displace the agonists that are bound to the mu opioid receptors, and because it is displacing opioids with a higher internal activation, what it can cause and has a high risk to cause is precipitated withdrawal. So this occurs when there's this change from a full agonist to a partial agonist like buprenorphine. In terms of withdrawal and measuring withdrawal, I just wanted to highlight in this slide that clinically, the way that withdrawal is screened for is using the Clinical Opiate Withdrawal Scale, or COWS, and just highlighted some of the most common symptoms associated with opioid use withdrawal here on this slide. The other thing that I do want to mention is another scale, which is the subjective opiate withdrawal scale, is another option that is a self-administered scale that a person or patient can use on their own to help assess if they are being started on buprenorphine in an outpatient setting. So the most common form and what is most predominantly used clinically to get people started onto buprenorphine is Suboxone. And what's unique about Suboxone is that it's a sublingual tablet, and it contains both buprenorphine as well as naloxone, and that's in a 4-to-1 ratio. And what's important to highlight is that naloxone does not have bioavailability that's significant when it's ingested orally or when it's absorbed sublingually. And it's really its bioavailability is increased and effective when or if it is injected. And the reason for having this component in Suboxone is to prevent diversion and discourage injection. So I wanted to review what a traditional Suboxone induction technique is before getting into what the new emerging strategies are. So because of those unique properties of buprenorphine and Suboxone with the high affinity and the risk for precipitated withdrawal, the general recommendation is if someone is going to be started on buprenorphine as the opioid agonist treatment, that they are to discontinue opioid use of either prescribed or illicit opioids about 12 hours prior to their day of induction onto buprenorphine. And I've included here a table. This is from the BCCSU guidelines, providing some indication for the minimum amount of time that a person should be off of an opioid before initiating induction in order to reduce or minimize any risk of precipitated withdrawal. Now, with the traditional induction, on day one, once someone has abstained from an opioid use, the COW scale is used to assess the severity of withdrawal. And once someone is into a moderate withdrawal with a COW score of at least 13, that's the point where the guideline recommendation is to start with the first dose of Suboxone. And that's typically at 2 milligrams or 4 milligrams using the sublingual tablets. And then it's recommended to reassess in 30 to 60 minutes after the first dose to assess if there has been any risk for precipitated withdrawal, or what we would expect is that there would be a relief of those withdrawal symptoms with buprenorphine binding to opioid receptors. And the goal with this guideline-based induction is to get to someone up to a maximum dose of 12 milligrams in the first day, or lower if less has been needed to help relieve the withdrawal symptoms. And then on day two of the, if there's no withdrawal symptoms present in the morning, it's to take the total dose taken in the first day and make that your starting dose for day two. But if there are still withdrawal symptoms present, to take that total dose from day one and add on additional Suboxone, and getting up to a maximum total dose of 16 milligrams by day two. So in this standard induction protocol, the goal is really to achieve an optimal stable dose where a person is able to sustain a 24-hour period without withdrawal symptoms, and also to ensure that you're not on too high of a dose where there's intoxication or sedation happening from Suboxone. So the challenges with a traditional induction are what I've highlighted, that it does require a period of abstinence from opioids along with subsequent withdrawal. And the other thing is that there have been patients who have said that they've continued to experience precipitated withdrawal despite abstaining from opioids for the recommended period of time before starting the induction. And what's being noted is that this may be due to fentanyl's lipophilic properties and its higher volume of distribution. And despite fentanyl's short half-life, this may explain fentanyl possibly just hanging out in the body for a longer period of time than expected, and maybe contributing to that. The other challenge is if anyone's had a prior negative experience with precipitated withdrawal, or if there's just a lot of anxiety around that. And then the other challenge is that if someone has opioid management for acute pain, that they would require a disruption to that pain management in order to get on to Suboxone. So that really brings me to the focus of the talk today, and that's to talk about what are the emerging induction techniques and the evidence around those, and those center around using microdosing as a technique to get rid of that phase of prerequisite withdrawal before starting on buprenorphine. So I'll be touching on what are the most common microdosing techniques, get into and some of the patch bridging methods as well, with buprenorphine patch bridging being the second most common technique. And then for completeness, I'll also touch on some of the alternative bridging methods with more limited evidence. And then I'll get into some of the methods for maintaining someone onto treatment. Because as we understand, in comparison to an opioid agonist treatment like methadone, one of the challenges with Suboxone is really retention in treatment. And it's quite exciting that there are new developments in having new formulations available to keep people or help people to stay on treatment long term. So to start with microdosing, the general principles of microdosing are really to slowly up titrate a patient onto buprenorphine while they continue either a prescribed or illicit opioid. And then the other, or the initial opioids that a person was on, those are stopped once a therapeutic dose of buprenorphine is reached. And what this does, and what the goal of this type of treatment is to reduce the risk of precipitated withdrawal. And the way we do this is through a gradual displacement of opioids and through a slow accumulation of binding the mu opioid receptors. So microdosing techniques, case reports for microdosing techniques looking back started to come out in around 2016. And I'm going to provide examples, some snapshot examples of some of the induction techniques that are most commonly used. When looking through different case reports, there's quite a variation. And also when gaining experience in the clinical and hospital setting, there's also quite a variation in the specific protocols used for microdosing. So what I'll provide is some snapshots of the most common ones, and there's minor variations around those strategies. So this first one that I want to show is actually a local example by Dr. Brar and others who had come up with a standardized protocol. And it's here, I've highlighted it on this slide. It's using a standardized protocol over 8 days to get someone onto a therapeutic dose of buprenorphine, getting up to 16 milligrams by day 8. In these two case examples, it was patients that were on slow release oral morphine. There were 5 other case examples in this case series where participants were on different opioids, but the same dosing technique was used, and it was demonstrated that these patients were able to get onto a therapeutic dose and discontinue use of their baseline opioid and avoid precipitated withdrawal. And I won't go through each of the details here, but what's important to note here is on day 1, a patient is being started on 0.5 milligrams in this protocol, and then slowly being titrated each day up to a total daily dose of 1 milligram on the first day, to 2 on the second day, 2 on the third day, and so forth, up to 16 milligrams. And so the big thing to notice in terms of the difference with the standard protocol is a much lower starting dose and a much slower increase in the dosing in order to avoid that precipitated withdrawal. So this is generally a good snapshot or an example of what standardized microdosing techniques are in the literature. And there's some variation in terms of that starting dose, and I'll touch on that. But the other thing that I want to highlight here is that in hospital, in clinics, we are seeing different microdosing techniques come up, and this I just wanted to include to highlight that there's even pre-printed orders here at St. Paul's Hospital for microdosing techniques, though what I've seen clinically is often a more individualized, tailored approach for microdosing, depending on where a person is at while doing reassessments. Now, the other term around microdosing is this term of rapid microdosing, which would be, there isn't a clear definition about what this is, but generally a faster titration, getting someone up to a therapeutic dose of buprenorphine in a shorter amount of time, less than a week. And this is an example here from a case series done by Dr. Claire and others, where there's an example of this dosing technique done over a 5-day period, and then the second table is demonstrating one done over a 3-day period and getting someone onto a therapeutic dose of buprenorphine and discontinuing their other opioids. And the same things to highlight would be starting dose and then frequency of the increase. And in this case, what is apparent and what is more utilized when doing a more rapid microdosing is a higher frequency of the smaller tablets being administered over the course of the days to more quickly bring someone up to a higher dose. And having the higher frequency, what that lends to is a higher frequency of actually assessing where a person's at, and then continuing on with higher doses. So in terms of since case series, so since about 2016, so over the last 5 years, there have been more and more case reports and case series that have been published using these microdosing techniques, but there hasn't been a very high level of evidence, such as a randomized controlled trial to show the validity of using microdosing in comparison to the standard Suboxone induction technique. And in the same regard, there isn't a universal standard induction protocol or a guideline-based protocol yet locally that's in place. But what I do want to highlight is that the range of the microdosing induction when reviewing the different case reports is between around 3 days all the way up to 29 days. And then the morphine milligram equivalent range for what which type of opioid or how much of an opioid someone was on before starting the induction also has quite a wide range along the case reports, demonstrating that it can be successful for a person who is on even higher doses of an opioid. And then the most common initial doses for that first dose when using the microdosing technique are in the range of 0.2 milligrams to 0.5 milligrams. And although I mentioned no RCT that's been done, when doing a search through clinicaltrials.gov, there is a randomized controlled trial that has been registered to do this comparison with standard dosing. And it's planned to be across 4 sites in BC and Alberta. And it'll be exciting to see once this gets going and when we see results for this to see like non-inferiority with the standard dosing. So that was to give a little bit of a tour through what are the most common microdosing techniques using sublingual tablets. The next most common thing in the literature is actually a variation of microdosing, which is to use a different formulation to start the microdosing technique, and that's a buprenorphine patch. And this was actually from a study that was published earlier this year, and this is the largest retrospective cohort analysis of microdosing, and it was over 72 patients, and there were 72 patients who were on an opioid and were wanting to start onto buprenorphine. And the most common reasons for initiating this technique for these patients was either there was co-occurrence of pain or there was a history or anxiety around precipitated withdrawal. In this study, the range was from 1 to 15 days, with the mean induction duration being over 6 days. And then the actual setting for the induction, the majority of these patients were started on buprenorphine in a hospital setting, and then there was also a percentage done through an outpatient setting. So this is an example from this study on what was their standard protocol that was used to initiate people onto buprenorphine. So there's 2 different protocols here, the standard one and then the acute pain protocol that they came up with in this study. And what's interesting here is on day 1, when using a buprenorphine patch, is they used a 20 microgram buprenorphine transdermal patch. So that's 20 micrograms per hour. So if you were to calculate that over 24 hours, that adds up to a total day one dose of up almost 0.5 milligrams of buprenorphine. And then the patch is continued, and then on to day two, a person is started on to 1 milligram twice daily dosing of the sublingual form and going up gradually until day 7 when the patch is removed and a person is continued on to their dose of buprenorphine sublingually. The difference with the acute pain protocol in this study was that the dosing of buprenorphine was done more distributed throughout the day to 3 times a day as opposed to 2 times a day and slowly bringing someone up. And the justification in this case was around pain management with having more spread out dosing in the day. So this is to give an example of in the literature what is the most common form of putting someone onto buprenorphine through the buprenorphine patch bridge. And then I'll touch briefly on alternative bridging methods. So these would be the ones with the least evidence, and there's very limited case reports. One case report was in the reviews was on using a fentanyl patch bridge. So this is quite limited, but the patient that was mentioned in this case report was on methadone, which was discontinued on day 1, and they were started on a fentanyl patch, 25 micrograms on that same day. They were continued on the patch till day 6, the fentanyl patch was removed, and then they were initiated on a microdosing induction. That was one example, and just for completeness, I wanted to include that, though it hasn't been validated or used or in many situations or circumstances. And then another case report, which I will also include, is that there was a case series where a person was transitioned onto slow release oral morphine and then onto Suboxone. And again, it was very limited case reports. So in regards to microdosing, the advantages of this approach, whether using it starting with sublingual or starting with a patch, is that it does reduce barriers for patients to get onto buprenorphine, and it increases the tools that we have to get people onto a treatment that works. And specifically the subsets of people that have been identified and who benefit more and who have more barriers are people with comorbid pain, a past history of experiencing precipitated withdrawal and therefore having a lot more anxiety about trying Suboxone again, or people who haven't tried it but have heard about a lot of those negative experiences of precipitated withdrawal. And then it can also be used in particularly for someone wanting to transition from methadone and not wanting to go through a prerequisite withdrawal phase. Now, the challenges with microdosing, so as I was mentioning with the sublingual tablets, so the lower dose of Suboxone and sublingually is available in 2 milligrams, and microdosing does require manipulation of prescription products to achieve smaller doses, and if we're getting down to like the 0.25 milligrams, that's really cutting a tablet down into 1/8, and that makes it quite challenging to really know if we're accurately giving the right dose. And so that is one of the challenges, and that's where the patch can come in. The other thing is that coverage for medications on an outpatient basis can also be a challenge. Other challenges with microdosing is when looking at the case reports, although there was no reporting of any severe precipitated withdrawal occurring, there were mostly mild and some moderate severity of withdrawal reported in cases. The other challenge of dosing, as I had mentioned, is just it is more resource intensive, especially if done in a hospital setting where there's a need for more frequent monitoring and reassessments if we're trying to microdose at a higher frequency within a day. And then the other thing is there isn't a specific validated microdosing protocol. And that can lead to there being a lot more complexity for the provider in creating a prescription with a dose regimen, and also for the patient to really follow. Because if, say you're starting a microdosing induction and you're providing a patient with the specific dosing for over 5 days or 7 days, and you can provide some education around using like a subjective withdrawal scale so that they can self-assess for signs of withdrawal as they're slowly dosing upward, but it is more resource intense. It does increase the complexity of getting onto a medication. And then the other thing with microdosing, especially compared to the standard induction protocol, is that it is a longer induction. Like even though there are studies looking at more rapid inductions, there is this potential of there being more lost prescriptions and there being potentially higher attrition rates for continuing on to therapy. So this brings me to summarizing what I've learned when looking through the different case reports and the case series on microdosing. And one of the big points to highlight really is that it is less important to follow a standardized microdosing protocol, and really it's more important to follow the principles of what is behind microdosing. And that the two main principles, one is this gradual displacement. So it's to start low and to go slow with microdosing. And the most common range is starting from 0.2 to 0.5 milligrams. And then the other big principle is this frequent reassessments. And one of the things I've seen in the clinic is if we're starting someone onto a microdosing regimen and it's going to be on an outpatient basis, if there is space for having a person in the clinic, you can even provide that first dose as almost a test dose and check in with a person after 20 to 30 minutes to see how it's gone, to see if there's been some relief of their withdrawal, if they're staying the same, or if it's actually starting to precipitate a withdrawal, to help be there to provide further guidance on how to continue with the microdosing, and possibly to provide supportive management around that. So those are really the two principles: starting low, going slow, and then the frequent reassessments. And then that last point on the slide is really, when I'm referring to cross titration, what that was referring to in the studies was at what dose of buprenorphine were people able to stop the opioid that they were previously on, and what's been reported is between the range of 8 milligrams to 16 milligrams, which coincides with where we're finding there are therapeutic doses of buprenorphine lie. So that's kind of the whirlwind tour through where we're at with microdosing techniques and what we're looking forward to going forward. And now I want to touch on switching gears from getting people onto buprenorphine to actually keeping people on buprenorphine. So there's different formulations. I've already spoken about the most common formulation, Suboxone. There's also a buprenorphine only form, which is used more in pregnant women because there is less evidence for Suboxone in that group. And then I've already also spoken about the patch, which can be used to help bridge for microdosing. There's a buccal film. Belbuca is mostly used for chronic pain, but there is also a Suboxone film, which I think there's higher availability of in the United States. But I bring that up because when speaking about those, the complexity of trying to get into a lower dose from a sublingual tablet, a film might be something that's easier to manipulate once that is, or if that is more available here. And then what I want to speak about now are these other two formulations that are a bit newer. So starting with Probufene, which is a subcutaneous implant. So Probufene is, so it's an implant formulation. There's a picture there here with the 4 implants shown, which the way this is done is they are inserted subdermally on the inner side of the arm via a procedure, an office procedure under local anesthesia. And what it provides is actually 6 months of sustained release buprenorphine and who it's indicated for are people who are stabilized on buprenorphine at a dose of 8 milligrams or less. So it is a specific subset of people who are on buprenorphine, but this is a good long-term management strategy. In terms of the evidence for this and the advantages, the drug trial that was done included 163 adults who were on 12 to 16 milligrams of Suboxone and then started onto this implant. And compared to a placebo group, it was demonstrated that there was better retention, less opioid use, fewer withdrawal symptoms, and lower craving scores. And then what was more interesting was that the phase 3 trial did a comparison between those who were on in the implant group versus those who were on Suboxone sublingually, and they found that there were clinically similar results between the two, which is reassuring. In terms of side effects from this implant, they're similar to sublingual Suboxone, and where it's more rare, but headache, drowsiness, nausea, anxiety, insomnia, constipation. And then specific to the implant are more localized adverse effects, localized swelling, pain, bruising, or bleeding at the site of implant. Now, the challenges and barriers with Probuphine, because I actually haven't seen this in clinical practice, despite it being approved in Canada in 2018. So it hasn't been widely adopted, at least here. And I think one of the big barriers is that it is approved for patients who are stabilized on no more than 8 milligrams of sublingual buprenorphine. So it would be on the lower end or the lower range of buprenorphine. The other big barrier, I think, for this is that there is provider burden, because there's a need for some procedural training on how to actually insert this device. And then it also needs to be removed or replaced every 6 months. So that it requires more procedural requirements that way. So that's really the summary where things are at with Probuphine. It is something that's approved in Canada and it's available. But what I have seen and what I find to be an even more exciting development in formulation is the monthly depot injection, which is Sublocade. So there's another depot injection as well, but Sublocade is the one that has been approved and is available here in BC as of April of last year. This is a monthly extended release injection that is administered in the abdominal region, and it's indicated for patients with moderate to severe opioid use disorder, and it's for people who are stabilized on a buprenorphine dose of 8 up to 24 milligrams. Some of the practical considerations are that patients who are initiated patients will become eligible to be started on Sublocade once they are initiated and stabilized on buprenorphine for a minimum of 7 days. There's 2 dosing formulations, 100 milligram depot and a 300 milligram depot. The goal with Sublocade is really it's designed to deliver at least 70% mu opioid receptor occupancy, which is what's correlated with reducing cravings and reducing use of other opioids while on treatment. And that's found to be associated with about a 2 to 3 nanogram per mil plasma drug concentration of buprenorphine. And what I'll highlight here is just the 100 milligram and the 300 milligram formulations and the concentration or the blood plasma ranges that they're able to deliver, showing that they fall within that range. So what's interesting with the phase 3 trial that was done for Sublocade is that they had randomized to 3 different groups. The first group received 6 months of the 300 milligram depot each month, and the second group received 300 milligrams for the first 2 months, followed by 4 monthly 100 milligram injections. And it was found that the abstinence rate was highest, but pretty similar to between these 2 groups. And that's really what guides the guideline recommendation on how to provide this medication. It's to give the first 2 months of the 300 milligram depot. That serves sort of as a loading dose to get someone onto a higher blood plasma level and to help stabilize, and then to follow up with 100 milligram doses to keep a steady state that's still within a therapeutic range. This is a patient-reported outcome study that was published earlier this year, where there was a comparison done between the monthly depot and daily sublingual buprenorphine, and patient reports did demonstrate over 24 weeks, or about 6 months, that there was higher satisfaction in the depot group. There were significant improvements in different measures, including the convenience, which makes sense, where as opposed to taking sublingual tablet that has to be absorbed over 10 minutes, this was a monthly dosing regimen. There was increased patient satisfaction, quality of life, as well as physical functioning. The challenges with this monthly formulation is some of the unique side effects are injection site-related pain, pruritus, erythema. The other is the risk of precipitated withdrawal with a long-acting formulation. And if you are delivering too high of a dose, the risk of sedation for a patient getting onto a long-acting formulation. And that's one of the reasons that there is this 7-day stability period recommended on buprenorphine prior to this transition to the monthly depot. Now, because this is a What's New talk, I want to get into some of the newest evidence around Sublocade. And this is actually a study that was just presented last month at the annual meeting of the College on Problems of Drug Dependence. And it was very interesting because it demonstrated 24 patients who received the first 300 milligram dose of Sublocade 1 hour after their first single dose of sublingual buprenorphine. So I'll very quickly just run through the diagram with the way that the study was structured, where people were asked, similar to a standard Suboxone induction protocol, to abstain from any long-acting opioids for 24 hours, come to the clinic, be assessed for withdrawal, and if they had a COWS score that was 8 or higher, they went on to pre-dose assessments, and then they received 4 milligrams of buprenorphine, which is similar to the standard induction protocol. They were assessed to see if they had any kind of allergic reaction. A repeat COWS score was done, and if there was a COWS score that had dropped and it was lower than 6, there was further pre-dose assessments done, and then they were started on a 300 milligram depot injection of Sublocade within that hour. So in this specific study, the most common adverse events that were reported included irritability, anxiety, nausea, and mild to moderate pain. What was interesting was that initiating a person onto Sublocade after 1 dose of buprenorphine, it demonstrated actually a similar safety profile to what the recommended induction directions are to start after 7 days in this study. And in terms of withdrawal symptoms, it was found that after getting that depot injection over the next 12 hours, there was ongoing improvement with withdrawal symptoms for people in this specific case series. And then that those improvements were sustained for those 4 weeks. So what is really exciting about this is that it actually just, it presents this opportunity possibly for a quick induction and maintenance, especially for a person who may struggle to get started onto treatment and to actually continue on treatment. And it's true with a lot of people we meet who have more chaotic lifestyles. It is difficult to continue on treatment, and this is one of the just new emerging findings or case series that shows that there may be other strategies to help get people quickly onto a long-term treatment. So that summarizes this whirlwind tour through what's new in getting people onto Suboxone and keeping people onto a buprenorphine-based treatment. And some of my take-home points from today's talk, it's to emphasize that the first-line therapy for opioid use disorder is buprenorphine-based opioid agonist therapy, that microdosing techniques do expand access to getting people onto this treatment, especially for people who have barriers of chronic pain or anxiety or past negative experiences with precipitated withdrawal, and that the most commonly demonstrated microdosing techniques utilize low-dose buprenorphine via either sublingual tablets or transdermal buprenorphine patch. And then the other thing that I was highlighting earlier, and I'll emphasize again, is that in microdosing, thus far, it appears that rather than sticking to the standardized protocol, what's being found to be more important is to really follow those principles of microdosing, the principles of the gradual displacement of opioid from opioid receptors with a low dose initiation, and then frequent monitoring and reassessment to ensure that a person is being up titrated onto a dose appropriately. So to really, at this time, have an individualized and tailored approach. And then with Probufene, it's really to highlight that it's available. It is something that's available in Canada, specifically for that subset of people who are on 8 milligrams of buprenorphine and wanting a more convenient dosing form going forward. And then that Sublocade is now available in Canada as of last year, and it's an easier to administer long-acting depot that can really counter the struggles with medication compliance and has demonstrated improved patient satisfaction. And then in terms of future directions, I've touched on this, that I'm looking forward to further a higher level of evidence to demonstrate microdosing. There's a Cochrane review that had demonstrated non-inferiority of Suboxone traditional induction with methadone, and I think we're at the stage where it'll be really helpful to get more validation of this microdosing technique in comparison with the traditional induction technique, and then to further explore the different dosing regimens, the different induction durations, and really to measure like one of the important outcomes, which is like long-term retention in treatment, prevention of relapse and prevention of morbidity and mortality. And then other future directions are the development of specific guidelines for microdosing techniques, and then to further explore induction techniques with possibly a more rapid transition to long-acting formulations, like I highlighted with the most recent study conference last month. Here are references of the different case series and some of the different reviews for microdosing techniques mostly. And then some of the clinical guidelines for the long-acting depot. And thank you so much for listening and joining in. And if there are any questions, then we could get to those now.
Excellent. Thank you so much, Daljeet. That was a wonderful overview of some pretty topical subjects, I think, in our world these days, and appreciate the emphasis on some of that newer literature. I will wait for questions from the audience. You can type them into the question box, but I'll get the ball rolling while we wait for further questions or for people to digest that. I'm curious, understanding you're still earlier on in your fellowship, if you have any pearls for us on how you counsel a patient who shows up in your office wanting to get onto buprenorphine, but with no preferences at all about how to go about doing that. Are there any specific factors you take into account when deciding on what induction strategy to adopt?
Yeah, I mean, initially really checking in with where the person that I'm meeting with where they're at, and being quite transparent about the different techniques that are available with the standard induction versus what's being trialed with microinduction, getting a sense of what their understanding really is of buprenorphine therapies, and learning about their knowledge base and if they have any apprehension. I find that in my past week and a half of being having clinical experience, there is a lot of apprehension and fears around precipitated withdrawal, sometimes from experience, sometimes just from hearing about it from other people, and providing just more education about how that comes about and how that can be minimized and the risk of it can really be reduced with a microdosing technique. And then what I found to be quite useful is, at least in this clinic setting, there is some space to allow people the option to be here in the clinic while being increased onto microdoses of Suboxone. And if someone is going to do it at home, I do actually print out some resources with some education around to look for signs of withdrawal and to decide on taking the next dose.
Excellent. Those are some helpful lessons, I think, and the key there being that it's a collaborative decision, I think, is a good one. So Raman has indicated we have questions from the audience. Raman, I will leave you to unmute.
Hello. Yeah, so just a question around somebody, who's on daily witness and has reported to somebody else that they are, I think, taking it out of their cheek and then smoking their Suboxone. And, is there any harm reduction with them still getting their Suboxone and ingesting it that way? Or, yeah, the questions around that.
So around harm reduction strategies, for that, I guess it would start with having that conversation openly about what the goals are for the person who's engaging in use that way. And then, so this was an example you were saying someone is continuing to be on methadone and then also using Suboxone.
No, only Suboxone.
No, only Suboxone. They were okay.
Yeah. So on a stable dose of Suboxone, Suboxone, when we could get a urine, is showing up in the urine, but then did report to somebody else that they were, smoking it. I'm just wondering where to proceed with that. Like, is he, still using some other substances? So is there still a benefit of prescribing it to get, if some are still going to be on the receptor, or is it not doing anything to discontinue it?
Right. Yeah. So like if they're the way they're getting into their bodies through smoking, is that actually even getting, because really if it's the sublingual tablets that they're modifying to do that, is there anything, and is there any benefit to that? My understanding is that really the bioavailability of it is through the sublingual absorption to actually get into the body for effect. I'll check in with Dr. Bach if I haven't come across that specific example, but if you have any specific suggestions around that.
Very interesting question. Truthfully, so buprenorphine tablets can theoretically be crushed and smoked. I think it's more commonly seen with the films that Daljeet's talked about that are more prevalent in the US and in Canada than the tablets, but it is something that's theoretically possible. I've honestly never I've encountered people who snort it, who inject it. That's not a common route of administration. But your question around how to counsel that patient is a good one. I mean, obviously, none of the data that Daljeet has explored today or really any of the data that we have for the use of Suboxone for treatment of opioid use disorder is necessarily applies to somebody who's smoking it. It would certainly not be my recommended route of administration. But if you want to look at it through a harm reduction lens, at least you know what they're using, as opposed to the contaminated drug supply that's out there nowadays. As far as potential adverse effects from smoking it, so you can overdose on buprenorphine, as much as we talk about it being a very safe medication. And the most common reason that people do overdose, and there are overdose deaths that occur, is usually from injecting it. So this may be a higher risk means of taking the buprenorphine. I'm just speculating, so I wouldn't say it's completely safe. But and I have no idea what kind of adverse effects you might expect with the other components of a tablet that you're smoking. So it's probably not something that I would recommend. It's certainly not something that I would recommend doing. But
okay, yes, thank you.
Yeah. But it certainly would be an interesting conversation with the patient. And you're right, well, you can say the same for the hydromorphone tablets that we're now prescribing, but none of those are meant to be injected, but we know people are doing that. Is that better or worse than the alternative? Many of us would, if we're looking at through that purely harm reduction lens, many of us are looking at anything other than fentanyl as probably a safer bet. Not that I would really endorse smoking your Suboxone tablets. So it's an interesting situation. Call up the race line. We'll have a longer conversation about it. That's quite an unusual scenario. So we have another question here saying, so I'll just read these aloud for you, Daljeet. So another question saying, one of the slides stated, taper a full opioid agonist after reaching therapeutic dose of Suboxone after microinduction with a patch bridge. Is this necessary?
Oh, tapering down as opposed to stopping all at once.
I assume that's what they're getting at, yes.
Yeah, so is it necessary? So really, it's like that is the goal, is to be getting someone onto a stabilized dose. And if you're getting enough of receptor like occupation with buprenorphine, then another opioid on board will likely not have that much of an effect, and that would be part of the goal. It would be with getting someone onto a stabilized effective dose of Suboxone. Doing a tapering method versus discontinuing all at once. Tapering down is definitely something that I've seen in the clinic being done with microdosing as an outpatient, is to slowly reduce the dose of another opioid that is being, and I think that does make sense practically for people in an outpatient setting. In more of a monitored setting, it may be either approach could really be used, as long as that I think end goal is what we're getting to, of having someone stabilized on an effective dose of buprenorphine.
If I can echo that, I think that we don't have any data, as Daljeet just highlighted repeatedly, to help to really suggest what to do in that situation. So I know there are different approaches out there. A couple comments here, Daljeet, then that are, I think, related to that previous previous question. Dr. Lapalainen in the Okanagan typed into the text box here. This is an interesting, referring to the smoking of Suboxone, interesting case. I suspect it would be a safer option than the full agonist safe supply, which is probably. I would agree with that, I think, but hard to say. If their goals are abstinence, she suggested to consider rotating to another form of OAT. And then a second question, I think referring to the same, well, I think referring to the same case, stating, I assume insufflation has the same bioavailability as sublingual dosing. So this case was talking about smoking of it rather than insufflation, but it's an interesting question. I don't know if you have any thoughts on that, Daljeet.
Again, I guess one of the things that I found when looking through case series, case studies is there isn't really data around that. And I think that assumption is true about there being lower bioavailability through other forms of taking in buprenorphine.
Give everyone I see we're already past 1 o'clock, so it looks like we don't have any other questions on here right now. I just want to thank everyone for attending today for, again, the first session of this academic year, and thank you very much, Dr. Mahal, for volunteering to take this on so early in your fellowship, and for doing an excellent job of summarizing, I think, a really relevant topic. Appreciate your work today. Thank you, everyone, and I hope to see you all next month.
Thank you.